we are live doing mental health review and substance abuse. Oh yeah, busy day today. So let's just jump right into this so we can have lots of time for this. I need my handy dandy laser pointer because I like that thing. Zoop. All right. Let's talk psychiatric nursing. The idea of people need more than a pill at times. They may just need a psychiatric consult. Medical issues can cause psychiatric issues. We've talked about, UTIs cause issues in elderly that look like psychiatric issues. Chronic illnesses, sudden losses can cause psychiatric diagnoses. What are some sudden losses that could cause psychiatric issues?
Access 4 type stuff, financial loss, housing loss,
Death,
disasters.
Yep. So what would be some of those illnesses that could come up?
cancer,
Yeah, the medical. What are some, if we think about this, what are some of these psychiatric issues that you think we're going to be talking about today? Like if we get divorced, or if, a family member dies, or we begin having status issues, what's one major thing that could show up?
depression. Yeah.
Oh, look at that. There you go. Depression. We also have things to think about like schizophrenia and bipolar that can kick into play. Now, we're going to think about the past for just a minute. It's the 40s. We have large state facilities. We don't really have any meds yet. All we pretty much have is the ability to hold these people indefinitely, and that's what they do. We hit the 50s. We've got our psychotherapeutic medications introduced and begins to help with that. And then our 70s hits. We have deinstitutionalization, patients' rights, and commitment laws. What are some things that this tells us?
What do you mean?
Deinstitutionalization. What is it not allowed to happen?
A lot of people were released.
A lot of people were released because there were no longer indefinite stays.
Mm-hmm.
They had to have least restrictive environments, which means if they could have outpatient, then they had outpatient. And they needed community care. So they were going to start having care in that community, and the state was going to pay for that. They were going to be reintegrated into society. Now, we get into the 80s and 90s, late into the 90s. What started to show up for a case-by-case basis of care?
Are you talking about it was more expensive?
Well, it was more expensive, but what was it called? What showed up to make sure that everybody was being treated individually, but financially it was being looked at case by case?
Case management?
Case management. Everything was looked on by a case-by-case basis. The idea of money drives the treatment now. People are sicker when they come in, and they leave when they're stabilized, not when they're cured or treated all the way.
Which created the revolving door effect.
Round and round we go. You go in, you're treated enough, you're stable, out you go. And more than likely we'll see you in about a week or two. Now, our first big thing we're looking at for stats is our GAF score. Subjective, meaning one doctor or nurse practitioner can give this score of 52, and another one can give them a 45, another one can give them a 60. Subjective. Used to rate social, occupational, and psychological functions of adults, 1 to 100. 100 is our big one. Superior, life's problems don't bother them. When are they going to be considered inpatient with a GAF score?
Below 30?
Below 30. Where are most mental health patients at?
50, 55.
Yeah. What is that 50 to 55 range? What are some, what are some descriptors for that point?
They might not be able to keep their job. They may have not, little friends, not many friends.
Right. Conflict with peers. All the way we drop down to that 40. If we drop down to 40s, we're thinking suicidal ideations, few friends, conflict with peers, maybe enough to keep that job. But if you notice, they still can't get their inpatient yet. So that causes that, it's really hard to move into that area. I mean, their ADLs are failing at that point. So, all right. So GAF score is one of them. What's one more thing that we really look at to help us define a patient?
The axis?
Axes. Yep. Charts used to describe the whole person, DSM-5. Don't forget that book is used to help standardize nomenclature, define characteristics, and identify causes of disorders. So, our axes are a set of 5. So, what's our first axis?
Primary diagnosis.
Primary diagnosis. So, what primary diagnosis?
Mood disorders. Any, psych disorder.
Any?
Major depression, bipolar.
So any disorder. So would that include mental
Does not
retardation?
include personality disorder.
And it also does not include mental retardation. So personality disorders, mental retardation. So if they're not there, where do we go from that? So what if I'm a histrionic? Where would that go?
Axis 2.
Oh, axis 2. Multi-dependent, narcissistic, clusters. Look at them clusters in axis 2, right?
Mm-hmm.
All right. So I think we got the idea. 1, 2, 3, 4, 5. So there's things. So what's axis 3?
Medical.
Yeah, medical issues, surgical, congestive heart failure, seizures, post-op issues, etc. So, primary mood disorders, traits, personality, medical. What's our 4th?
Stressors.
Housing, financial, family, etc. And then our 5th axis is what?
GAF.
Actual GAF score. And don't forget, less than 30 is inpatient. You get to 50 to 55. Highest usually seen in a psych patient. Now, what are our 3 treatment settings?
Inpatient.
Inpatient,
Outpatient.
Mm-hmm.
outpatient, partial hospitalization, right? And
Rehabilitation.
residential.
Okay. Residential.
Yep. So those are our treatment settings. So with partial hospitalization, what's our goal when we're doing partial hospitalization?
To get them well enough to send them home.
Transition them to independence.
Mm-hmm.
Now, what are we talking about with residential treatment?
They just live in a place where they're supervised.
Yeah, a community setting, 6 to 10, they're supervised, making sure they do well. Certain people like schizophrenics, a lot of times they need this for their whole life. They can do very well as they get into this, but they, like schizophrenics, they need to have this their whole life because for the most part they can't live on their own. All right, inpatient hospitals. What would you expect to see them, if they're going to be an inpatient, what would you expect with their ADLs, if you know that they're an inpatient?
They probably need a lot of help with the ADLs.
They probably can't do their ADLs very well. What about their GAF score?
Below 30?
Below 30. What about lethality assessments?
You mean like suicide? You have to assess them, make sure they don't have a plan?
Right. So if they're inpatient,
Gotta watch them.
they've probably got a plan. Harm themselves, others, suicidal thoughts with a plan, but they also could just have suicidal ideations that people were worried about. Now, let's say these patients come into an ER. Again, we've talked about this. We see them in the ER. We can't bring them in inpatient, or maybe we can for a very short amount of time. Because of case management, what's going to happen? How are we going to treat them?
They'll probably, because of the expense of it, try to do what they can to get them stabilized so that they can go on outpatient and have it instead of being inpatient.
Yes. So if when we start our outpatient discharge planning, what has to be included in that?
A referral to the doctor?
Yes. Rapid assessment. Stabilize them. Discharge planning. Outpatient treatment includes a doctor's appointment. They may not follow through. They're not being cured. They're just being treated. But we may have them for a little while. We can educate them on their ADLs and self-sufficiency if we have them for 3-4 days.
Mm-hmm.
All right. Rehab programs. What is a rehab program?
It's a program that helps bring them back into society, rehabilitate them.
Designed to promote the recovery.
Mm-hmm.
What are the goals?
It's a good question. You should post those goals.
Improve their quality of life.
Yes.
That they can do their ADLs a little bit better.
Mm-hmm.
They can recover or to the best stabilize their mental illness so they can, join society or function in society. I'm sure there's lots of other things.
Personal growth, reintegration, as you said, empowerment, and decrease the number of readmits.
Mm-hmm.
Now, what are our special populations we're dealing with?
The homeless.
And?
Prisoners.
Prisoners, yes, yes, yes. So, when we're talking about homeless, what are we worried about with these patients?
Well, they don't have any money for their medication.
Yeah.
Whether or not they're even taking their medication.
Mm-hmm. So we sent them homeless for 3 or 4 days, and a prescription for 90 days more. How are they going to get those? Where are they going to get them from? Are they going to take them on time?
Mm-hmm.
Are they going to make it to that doctor's appointment? Why are they homeless? Is it because of the disorder or something else happened? Are they one of those few that, actually like doing that? We have to think about, what happens if we increase that support? Because sometimes, as we've seen in some of those actual journal articles, if you actually support these patients, society supports them with education and a place, they actually get out of this situation. Prisoners. What's special about the prisoners when we're talking about mental illnesses?
Most of them have a personality disorder.
Yes. Is that a disease?
No.
Nope. But remember, prisoners, you have a higher than average percentage in the general population. So, that fits in there too. It's related to deinstitutionalization, rigid civil commitment requirements, and lack of community support. So, again, if you think about these patients, they have all these issues, they can't afford treatment, and all of a sudden you see them doing something that's against the law. Criminalization of that mental illness, 4 times more likely to be arrested and prosecuted without treatment. So we could pay $29,000 a month for their treatment, or we could pay $29,000 a year to keep them in a cell. All right. Assessment of psychiatric patients. Determine emotional status, mental capability, and behavioral function of the patient. What are we talking about here? We're talking the ability to help meet emotional need. It gives us a baseline. All assessments, when we first do it, give us a baseline to work with. And then we can evaluate and evaluate progress as we've gone through to work from that first baseline. When we're doing these assessments, we do not rush, we do not judge, we do not fear, because they will sense that fear. We need to relax with these patients. Now, what factors do we need to watch when we're assessing these patients? What could cause an issue when we're assessing?
We need to determine if there's anything physiological first.
That's part of assessment, right? But I should say with this, what factors would affect our ability to simply assess them?
Oh, if they may not be
We gotta make sure they understand the language we're speaking to be able to assess them, because you'll be asking them questions.
Yes. Can they understand? What else? You're doing awesome. You can do it.
We want to make sure they don't have any other physiological issues, like if they have a UTI or something else that might be giving them those symptoms that could be confused as mental.
Yes, the physicals before the psychiatric.
Yeah.
Our participation, are they willing to participate with us? That's going to affect us.
Mm-hmm.
Their health status in general. Are they in a coma? Good luck assessing that psychiatric portion. Are they in their manic mood? If they're, say they're a bipolar 1, or if they're bipolar, are they currently in manic? Because that's going to be a little difficult. Previous, experience with health care. Ability to understand. And nurse's approach. And as you guys have been saying, boom, oh, wrong button. Boom. Assessment, visual first, then the physical assessment before any psychiatric assessment. Things like UTIs, hypokalemia, hypermagnesemia, cardiac disorders, hypoxia. So many things will show up with psychiatric issues as symptoms if you do not look for those first. You'll start thinking about, oh, we need to treat this, this delirium with a pill, when if you just treated that hypoxic issue, it would have gone away. You need to figure that stuff out. All right. Time to how to. Remember, when we're assessing somebody, we don't ask why. So, whenever we're talking to them, we give them time to respond. We don't want to rush anyone to questions. Don't ask them multiple questions in a row, and sit in accepting body positions. So, for the environment, first off, what does the space need to look like for them?
the room. The conference room is usually good, well lit.
Okay.
Personal space, I think, is it 18 inches?
18 to 36 inches.
Yeah. And don't forget, what's always on our mind, no matter what we're talking about, whether it be psychiatric or any other patient?
Safety.
Safety! Don't seclude us. Don't seclude them. Now, some patients need input of their family or friends. They may need them to be present, or they may need them to not be there for them to talk. Sit in that accepting body position. Don't look at our watch. Open body. Unfold our arms. Don't slump forward, but you can lean forward, showing interest, right?
Mm-hmm.
What type of questions do we use?
Open-ended.
Yep, open-ended questions. What are some key words that we use to remember open-ended questions?
Tell, how, what.
Our questions should give us more than one word answers. Yes, no, okay, or not good responses in an assessment. All right, so we're sitting there talking, and they happen to mention suicide. Okay? We're doing our history. We get some information about harming themselves, attempts and family suicide. Don't forget that does increase their risk. So, we have a patient. They're thinking about some suicidal ideations, okay? Do you have a plan? We need to find out. Now, what happens if they have a plan? What happens next?
You keep asking them questions.
Confront. We need those direct facts. So, what do we say?
What's your plan?
Boom. What else?
When do you plan on doing it?
Boom.
With what?
Oh my goodness.
Do you have access to those things that can harm
Oh.
Is there a special date?
Oh, you just ruined it.
That's perfect.
Where?
What time are you planning on killing yourself? Is there a special day you plan on killing yourself? Birthday, anniversary, death of a child, etc. Why do we keep mentioning, killing yourself? I could say, what is your plan to kill yourself? When are you planning to kill yourself? And what are you planning to kill yourself? Do you have access to the tools to kill yourself? Where would you kill yourself? What time are you planning to kill yourself? Why do you keep saying that?
The more you talk about it, the least likely they're to do it.
Talking about it will not cause the patient to commit the act. Will actually decrease the likelihood, right?
Mm-hmm.
Now, let's keep going with assessment. What's our first piece of assessment? Once we've gotten through the physical.
The history?
Yes, personal, familial history. Things like schizophrenia can have a familial history, but no matter what, we need to know about that history, no matter what we're talking about. So, what's next?
Their appearance?
Appearance, right? We're looking at age. What is this patient? Does the patient look their age? Are they appropriately dressed? Developmentally appropriate? Because if we're talking about, say, drug use or any type of abuse, substance use, this can affect their age. Mental issues could affect how they dress or how they act, right? And then, as you said, also general. Are they kempt, unkempt, clean, posture? Remember, no eye contact is bad. We want them to have eye contact with us. Any tics, tremors? Are they snapping their fingers, tapping their fingers? Some general terms for us. If they are moving slowly, what would that be?
They're affect? No.
Movement. Full body movement is slow.
Psychomotor retardation?
There you go. The automatisms is that repeated purposeless movements, and the waxy flexibility is that frozen in time. And just one more, thinking about it. All right. If we're talking about our pervasive, enduring emotional state, what are we assessing? Our mood. Remember, we have mood and affect. Mood is our emotional, enduring emotional state.
Okay.
Whereas affect is how we show.
Yeah.
So,
okay.
Let's do our mood. We have 3 basic levels. We have our normal range, which is what?
Euthmic? I don't
Euthmic.
know if I'm saying it correctly.
Euthmic. It's just like eupnea for regular breathing. It's euthmic for normal range. Or euthymic, if you want. Okay, then we go up a level. We go higher than normal. What would that be?
Euphoric?
That's all the way up there.
Oh.
Elevated euphoric.
Okay.
Oh. Just elevated?
Yep. Euthmic, elevated, euphoric. Now, let's say they're depressed, anxious, and irritable. What would we say? They're having a harder time with their mood.
Dysphoric.
Boom.
Yeah.
Now let's say they are acting larger than life. This can go both ways, all the way up, all the way down.
Expansive.
There you go. Think
Lot
of
of
manics, bipolar. And if they feel, tension, easily annoyed and provoked, we think about irritable. Now, we're thinking about affect now, the outward expression of emotional state. It can be stated or inferred from data. I'm elated, I'm sad, if it's stated or inferred from data. Tone of voice, gestures, expression. Now, if it's normal, what do we use here?
Broad?
Broad. If we have a slight reduction, what would that be?
Restricted?
Yep. And let's say the expression's actually different than what they're showing, what they're saying.
Appropriate.
That's right. Quick change.
Labile?
Go. Severe reduction with only small amounts of facial movements.
Blunt. Blunted.
Yes. Severe reduction with some facial movements. And then no facial movements. Nothing.
Flat.
Flat. Boom, boom, boom. No motion, tone, no facial mobility. All right, let's do their psychomotors now. So, normal movements. Not fast, not slow. What would that be?
They're calm.
They're calm. And then if they go a little faster, excessively fast,
Agitated.
and if they're slow,
Retardation.
oh, bam. Don't forget, retardation includes visible slowing of physical reactions, movement, and speech, because speech is a motor function. If there's repetitive motions, obsessions, you'd have to think about what?
Compulsive?
Hey, that should be pretty simple. Repetitive obsessions, compulsive. What would be withdrawn?
Yeah, distance yourself.
Both physically and emotionally. Now, motor anomaly, physical and psychological immobility.
And catatonic?
Yup. Next one, thought process, how patient thinks and obtains speech. Answers in excessive circumstantial detail. So, how are you today? Oh, I'm doing fine. I'd love to be able to go do something else today, but I can't right now. I've got to go take care of this dragon and this dragon over here, and I've got to eat all of my food right now. But let me tell you about this.
Circumstantial.
But they answered the question. What is it when we have a fixed false belief?
You have, yeah, delusion.
Excessive amount and rate of speech with fragmented ideas and unrelated ideas.
Is that when they're going from one thought to another? The fly goes?
Wee, boom, 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 boom. Ideas of reference, inaccurate interpretations of events directed to him. What personality disorder, personality type had this?
The schizotypal?
Schizotypal, yep.
Typal.
Which, by the way, we figured out a famous person you could think of as schizotypal.
Who?
Lady Gaga.
Ah.
Disorganized thinking, jumping from one idea to another with no real relation.
They're loose.
Yes. So remember, flight of ideas is excessive amount and rate of speech with fragmented, unrelated ideas. Or loose associations is just the same idea without that excessive amount and rate of speech. Circumstantial is answering in circumstantial detail, but it's actually answering that question. And Hispanics is actually put here because of our friend Monica, who's on here. She told us that Hispanics are very much like to answer this way, right?
Yeah. If you ask them how they're doing, they're going to tell you everything about their anatomy before they actually tell you they're okay or not. That's what organs aren't working.
So let's move on to sensorium. Sum of organisms' perceptions. We have our orientation times for person, place, time, purpose, and memory. So, what other things are part of sensorium? Their ability to do what?
To be able to orient,
Concentrate.
right? Concentrate.
Yep. Counting, spelling backwards, or we can assess this. Get them to count and spell backwards. Now, what else would we? What other part is of the sensorium? We check this with proverbs and interpretations.
Their abstract thinking.
Yes. Now, alterations. What is the alteration in the sensorium?
Oh, the hallucinations. 'Cause
Yes.
they can smell popcorn when there's no popcorn.
Yes.
Or orange juice.
Yeah. Well, hey, leave my orange juice example out of this.
I'm just reading.
False perception based on the five senses. You may tell the patient you do not see, hear, taste, etc. Right? But then we have to remember, now this isn't necessarily part of that sensorium. This is part of that thought process. But just to kind of bring it back, hallucination versus delusion. A fixed false belief. I'm the Queen of France. We don't acknowledge that. We redirect. Now, legalities. Go on. Involuntary hospitalization, GFR less than 30, committed involuntary. They're going to be a danger to themselves or others. How quickly do they need to be seen if they're coming in?
Then 12 to 24 hours.
Within 24 hours, right? Or they're going to be free. What right do they lose? If they're just involuntary committed hospitalization, not the committed.
They lose their right to be able to leave.
Mm-hmm.
Yeah, right to freedom. How often are they going to have a hearing about this?
Every 14 days.
Well, bang. Now, if it's court-ordered, they're a court-ordered commission, who can change the orders?
The court?
Judge only. Yep. Now, our other version, voluntary, willing to seek treatment. How long should they be staying, at least?
At least 12 to 24 hours, long enough to be able to see a doctor.
Yep. They have no rights lost. They can refuse treatment. They just, are being seen. A little more legalities. Let's say they need to be inpatient, but someone's willing to take care of them, so they don't have to be. Thanks to, the idea of least restrictive environments, they can have a legal guardian. What would that be called?
Conservatorship.
Boom. What does that patient lose with their rights, though?
They can't sign any legal documents, so that covers a lot of things.
Yep, they can't vote, they have no legal contract, really, they can't write checks, etc. Remember, thanks to that least restrictive environment, this allows this kind of thing to happen. We can't use restraints, because remember, it's a form of battery, unless you have that order. Seclusion is involuntary confinement. Torts, wrongful act that results in injury, loss, or damage. What are our two overall types of torts?
Intentional and unintentional.
Right, so let's start with unintentional. What are our two types in there? If I did not cause harm when I did it, what would that be?
Negligence.
Uh-huh. So the idea of I didn't mean to cause harm, or didn't cause harm, would be negligence. And if I caused harm, or meant to,
Malpractice.
well, intentional. What are our big three things on this one?
Assault.
Yep.
Battery.
Uh-huh.
False imprisonment.
Yup. What is assault?
Assault's like when you threaten.
Yep. Intending to cause harm, a threat. So if I say I'm going to put you in restraints if you don't calm down, you've just committed assault. But if you say, like, I'm going to have to control you if you don't stop, harming people, you don't want to say that word, but you don't want to threaten somebody with, physical force. But you have to, you have to tell them that we have to control the situation. There's safety issues, right?
Right.
Mm-hmm.
Battery is the actual contact, and there's that false imprisonment. Oh, yo, we did it.
Okay.
That was our first one.
One down.
Painful. Painful.
Why don't we take oh, Robert's on. Hi, Robert.
Robert.
Oh my goodness, there's 12 messages. Oh, Robert can't come off mute. That's because I have to take him off mute. Cameraman. Let's see. Shunk. All right, let me take care of this real quick so we can get you in here, Robert. Do. Right. Hello, Jennifer.
Hello.
How are you, ma'am?
I'm good. How are you?
Good. Didn't you get the invite?
I was not in front of my computer. Sorry.
We're taking a quick 10, so we just went over a quick review, and we are doing recording, just so you know. So
When did you start?
40 minutes ago. I don't even know how long we've been on here. We just literally did the review chapter. We're about to do substance abuse.
Okay.
Go ahead and unmute yourself, Robert. You should be able to now. Now, okay, log out and log back in, because I've unlocked it, so you should be fine. And if you're watching this, feel free to jump forward, because Dancing Dave is not always the funnest thing to watch.
After we're done, I need to ask you a question about computer stuff.
That's me!
So when we're done and
Absolutely.
not recording.
Absolutely. Good morning, Robert.
What the heck?
You're on. What?
Okay, it was saying something weird. It was saying something funky.
Your face is something funky.
Did you see I was typing answers, though? I was
Yes. Well, I couldn't see. Well, I did. You were answering.
like, well,
You're like, well, I might as well join. I was trying out that mute function in case I didn't have access.
yeah, it works good because it was like, you're just going to be hidden from the rest of the group. And then I'm trying to hit the microphone, and it's like, no, no, no.
You came in late, so you get to be quiet until I have access to let you in.
I want to play too.
Yeah.
Died in the middle of a horde and killed myself so I could come.
Hey. I even waited an extra 10 minutes to start this up, so that's on you.
Well, when you're having fun with your kids, you know.
Yes, I understand. I wish. Do 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 boo 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 boo.
For tomorrow.
Again, just you know how this works. We're online, so.
Yeah, I printed the little matching thing from D2L.
Oh, you mean for tonight?
Well, for tomorrow.
You mean for tonight?
I printed like 5 of them. No, for tomorrow, for other people to do if they wanted to fill it out.
Oh, gotcha.
I take it that was something we're going to have to hand in Thursday.
Do 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 do.
And I'll watch a couple amazing races that I've missed, so that'll be watching TV.
I don't have TV. All I have is YouTube.
Hmm. Yeah, but that one's just like watch TV and then we'll talk over it and discuss it. I mean, you can BS that one. But I don't know if she's going to want us to actually turn that matching stuff in.
That should help us anyway understand it. And I have some good news for tomorrow as well for those of you who want to for Monday.
I can come help you Monday if you want now.
Well,
Did that kind of fall by the wayside?
because of the weather, we've had to postpone some of it. We've had to postpone.
I didn't know if Alex had posted anything yet, but she gave me the boot.
Online recording. Online do.
Well, now everybody knows. Sorry. It's all good.
Got a few more minutes till we start.
All those terms and everything you did in the beginning, I think that's the only things that I'm just like, I don't have, like, down so far.
From the review.
Yeah.
Yeah, and most of the terms are starting to stick because we keep hitting them. That's the point. As we hit them, another one sticks.
All the
Another one
schizophrenia
sticks.
stuff, all the substance abuse stuff, all the personality disorder stuff. I got a good hold of all that.
Be careful with that.
A good hold. Not an excellent hold, not a really good hold, just a good,
A generalistic hold.
yeah.
Okay, I can go with that.
Just all those little individual terms that you just went over, that was like,
I did the RAM thing today,
How
and
was it?
Miss Rogers had good things to say about this study group.
Beware, names.
Oh, sorry.
yeah,
Shoot.
we're live.
I can edit that. Just,
I'm sorry.
it's all right. Just, not a big issue. Just keep it. I thank you for letting me know, though. All right, we got about a minute left. So how did you like RAM? Remote area medical, I cannot do anything but plug them. I loved working with them.
Today didn't go quite as well as the other one, from what I understand. I mean, it was good, but it was just very different because it was the veterans stand down. So it's very different than a traditional RAM. But I liked it. I mean, I enjoyed being there, but it was very different. They told us to be there at 5:15, and we weren't really supposed to be there until like 7:30.
Oh, good.
Yeah. So we just sat there for a really long time. So it was that was kind of, and then it wasn't like people weren't lined up. They were busing them in, I guess, from areas
Did you guys?
because it was. I'm
Did you guys?
sorry.
I was saying, what was you? Were you guys in blood pressures or?
Yeah, we did triage.
Oh, wasn't that fun?
Yeah, I mean, I enjoyed getting to do it, and we got to go see like how they make glasses and stuff. That was kind of cool.
That's what I got to do at the second portion of it. I actually got to help start doing that.
Really?
Oh yeah, I was helping them with that.
That looks so cool. But I think there was only like, they were only expecting like 200 people because it was a veterans only thing.
Right, absolutely.
So,
All right. Oh look, I got food delivery in the middle of recordings. I love it.
Woo!
All right. Sorry it took me an extra minute, but I wanted to make sure this looked good for our next show. Yeah.
On the show.
All right, ready to go. Boom. Now, if anybody has any issues, again, if there's any feedback, please let me know. I can end this show. just for a moment to mute somebody or rotate something around if necessary. Because here we go. Do, 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 do. All right, moving on in. Substance abuse it's like eggs with your brain on drugs. And then you smash it against windows. Is your family? Is your friends? Is just, oh wait, wrong. That's the 90s commercial about it. Same thing. Labs. Same idea. Just to kind of remind you, these are things that we can take. Liver functions depending, ultrasounds, ammonia levels. Remember, with ammonia levels, the higher they are and the longer they stay there, the brain can actually deteriorate. CBCs, CMPs are pretty much pulled with every single one of these. Your analysis.
Is the PowerPoint supposed to be on the screen?
No, yeah, absolutely. It's supposed to be on the screen. I totally didn't do it, did I? You're supposed to see my pretty face. My pretty face.
You're nice to look at, but we want to see the PowerPoint.
Well, thank you, Jenna. At least somebody thinks that.
Mm-hmm.
All right. One more time. As I was saying, as I was saying, this is our family. This is our brain on drugs, and then we smash it against glass, and then that's our friends and our family and our social life, yada yada. All right, labs. Depending on the drug and what we're using, we're going to check things like our liver function, our AST, ALT, because those will go up if we're having issues. Ultrasound ammonia levels, again, they go up when the brain deteriorates. Or excuse me, as the ammonia levels go up, if they stay up, the brain will deteriorate. We have our CBC, CMP, which is pulled for everything. We need to see our blood count, metabolic panels. Your analysis, and our CPK. Creatine phosphokinase is going to tell us if there's any major organ failure, like heart, lungs, brain, liver, but this will just be a general number. Oh, wait a minute, I'm sorry. Ah, that's better. So this is going to be our general number. If there's an issue, we then have to go into further testing, like our liver function, AST, ALT. See if it's our lung, or see if it's our liver that's having an issue. Go in and see if maybe there's a test for the brain. You know, get an ultrasound, get our CT, figure out what's causing that CPK to change. We have our schedule of drugs. 1 being a high abuse percentage with no medical use. LSD, ecstasy, peyote, cocaine. Schedule 2, high physical dependence with the medical use, though. Cocaine, Dilaudid, Demerol, and then it goes down from there. Just a review of cirrhosis. What is the main cause of cirrhosis?
The nutrition deficiency.
Right. Malnutrition. They're not eating. So what's causing this cirrhosis or scarring?
Taking protein from the liver.
Yeah, that's going to cause scarring right there. What's our treatment regimen for this?
Folic acid and thiamine.
Folic acid and thiamine. Why do we give thiamine?
For muscles
A little more.
and muscle mobility.
Yeah, we need thiamine for muscles to actually work, right? For them to actually be able to contract. How do we give that?
Injections.
Injections for
Yeah.
how long?
The first 3 days.
And then how do we give it?
PO.
Yep. So we got IM for 3 days, then PO. And then, of course, your idea for folic acid is help to improve generalized health, and there's other things that will help with that. But thiamin's great for that needed muscle contractility. Now, quick review on the autonomic nervous system. Sympathetic, parasympathetic. Tell me about sympathetic, what we're talking about, what we're discussing today. What's sympathetic also known as?
Fight or flight.
Fight or flight. What happens to our pupils?
We run from the bear, so they dilate.
That's right. Run from the bear. Got to see everything. Oh my God! Oh my God! All right, dilate. And if we're going to run from the bear, are we going to want to breathe?
Yeah.
Yeah. Probably want those bronchioles to dilate as well. Bronchioles and the pupils do the same thing based on that sympathetic or parasympathetic nervous system. Run from the bear. Open up. All right. We've run from the bear. We hide in the cave. Sleep it off. Rest and digest. What happens to the pupils?
They constrict. You don't need to see anymore.
No, we don't need to see. Meiosis. And then what happens to the bronchioles then?
They will constrict some too.
Yep. Don't need them as much. That's the general idea when we start thinking about that CNS medication, right? Talk about those depressants. All right. Now let's go into the meds that actually deal with this stuff. When we're talking about stimulants and depressants, what are we talking about when we're discussing it? Which system?
The CNS?
Right. Sympathetic or parasympathetic?
Sympathetic.
Yeah. Both of these affect the sympathetic. One will stimulate it, one will depress it. By stimulating it, it will allow the parasympathetic to go away. By depressing it, it will allow the parasympathetic to take over. Simple enough. So if you stimulate it, boom, there it goes. If you depress it, this goes. So stimulants stimulate the sympathetic nervous system. Therefore, parasympathetic is suppressed. What would you expect to see with the pupils?
Be dilated.
Dilated. Run from the bear. Yeah. Lose your hallucinogens. And if it's a depressant, depresses that sympathetic, allows the parasympathetic to take over. Every one of these will have the issue of respirations decreased and aspiration issues. Pupils will constrict, and this includes narcotics. The issue on this one, that strange one, is those alcohols. Dilation. But even that has a special rule. But generalizations of addiction. We're looking at alcohol today, amphetamines, cannabis. You gotta cook it. Hallucinogens, inhalants, opioids, PCP, sedatives, hypnotics, anxiolytics. Definitions. So, define substance abuse for me. I'm a new nurse and I forgot what it was. Quick, help me before I take the NCLEX.
It's the use of any drug that is not consistent with the medical.
Does it have to be a drug?
No.
Nope. Nope. Just substance. Drug or substance inconsistent with that medical social norm. Tylenol, alcohol, opiates, etc. Now, let's say I begin using alcohol. I'm 14. I decide to use alcohol. I use it till I'm 45. Regularly. What's more than likely going to happen with my body?
You're going to depend on.
I'm going to become dependent, besides the fact that I'm having cirrhosis and my body's dying. You're going to become dependent. You're going to start showing signs of tolerance, withdrawals issues, or unsuccessful attempts associated with those addictions. The body's going to need it. So if the body needs it, not about getting that euphoric or that, those inhibitions dropped or anything. If the body needs, based on dependence, is it based on the same amount of alcohol or an increased amount of alcohol? The body needs it. It requires the same amount each time. That may change based on how much you drink as well, but if that body's used to having that, it needs to have that certain value, that certain level in that system. Or you can start going into withdrawals. Now, what is intoxication exactly?
When you take a substance and it results in a maladaptive behavior.
Great. I'm glad you can read. Tell me what maladaptive is.
Maladaptive is like you start to stagger, slurred speech.
Give me the actual, like, what is maladaptive, though? Like, there's adaptive behaviors and maladaptive behaviors. Because those are part of maladaptive behaviors. But do you remember what maladaptive was?
The actual maladaptive? Like what
Yeah.
the word means?
Yeah.
It means that you're not adapting. You're adapting poorly. Bad.
Adapting poorly. Adapting poorly. So if, let's say, I'm stressed out and I want to do an adaptive behavior, I'll go home and play a video game or go home and read a book. Versus maladaptive, if I'm stressed out, I'm going to go home and blow something up. Not so much a good thing. Now, there's intoxication. What would be detox at that point then? That's that safe
Is that when you
withdrawal.
safely withdraw?
Yep.
Okay.
Let's start with our favorite one. Alcohol. CNS depressant. Our labs are here. Liver function. CBC. CMP. Special on this one, it will dilate those pupils. Again, it depends on what point of the night you're looking at them, but you're going to see dilated pupils. When do you start? When do most people get their first intoxication?
In their
Usually
teens.
in their teens.
Yeah. Late teens. Why? What's that related to? Peer pressure. When do they start increasing that number? When do they start drinking more and more?
Mid-20s and 30s.
Mid-20s and 30s. Related to age as well as what?
Nursing program.
Did I hear Axis?
Yes.
Oh my God, yes, Axis 4. Thank you. Stressors. I love you. Thank you. All right. So, when a person drinks too much, I have no idea, let's say tequila, and I have no memory of awareness of what's occurred or what's occurring, what would that be?
Blackout.
Blackout. It's easy enough. Now, if a person needs to drink more and more to be able to get drunk, what is occurring?
Tolerance.
Yep. Tolerance. That initial effect of intoxication. Now, let's say somebody takes a month off of drinking, or a month off of smoking, or whatever. These terms fall under most of these. When a person takes a month off of doing anything, and then they go back, and they only need a little bit, and they get intoxicated again. What was that term?
They just take a break from their tolerance.
What tolerance break? This is the reason that alcoholism is a disease. One drink post-sobriety can make a person intoxicated quickly. So it's an issue. It could be 10 years down the road that it can cause an issue. So what's the initial effects of alcohol? After a long, hard day at work, you drink this, what are you trying to do?
Relax.
Relax. Or inhibitions. You rapidly absorb this with the bloodstream. Only 20% gets absorbed through the stomach, though. The other 80% goes through your GI tract, and that's an issue because you don't quite realize it takes a little bit to get there. Now, you've got your initial effect. Now you're getting to intoxication. You're through to intoxication. What's happening?
Good. You're depressing your CNS, so your motor skills start to depress.
So what are your symptoms?
Blurred speech.
There you go.
Unsteady gait, and your memory and your judgment becomes impaired.
Personality change. Loss of concentration. What happens if you overdose on this? Yeah. It's a depressant. You'll stop.
Oh, I figured you'd black out before you stopped.
Yes, but once again, think about absorption. It's rapid.
Mm-hmm.
But 80% is through your GI tract. Let's say you just took 30 shots. You packed out and you're still digesting. You can overdose.
How often does that happen with alcohol?
What college are we at? That's the question. Are we at that? That's what I mean. Not our college necessarily. I'm just saying what college, what are we at a college? Are we at a place like an adult party? Are we at somewhere where they should
like the butt chugging.
Butt chuggington type thing,
Okay.
It depends completely on the situation. If you have a whole bunch of 18-year-olds who shouldn't be drinking, they're going to try stuff out.
If you were doing something like that, the whole butt chugging thing, would you have the symptoms of relaxation and all of that, or would you?
Well, yeah, absolutely. Think about it. You're going to still absorb everything. You've got your membranes. You're absorbing that alcohol. You're going to get those feelings. You're also going to get toxic really quickly because you don't have anything filtering that.
That's what I was.
I thought you didn't have the relaxation if you do it because it's straight into the bloodstream because the mucous membranes are so thin. You don't even get a chance for the liver to process it. That's why it's the first pass.
The idea here is most of the time, because we talked about this, most of the time they're going to be doing, if they're doing something like that, they're just going to stick a whole bottle in there. They're not going to have the chance to relax. They're out. If they stick a wine glass in there, they might get to relax. But again, this is an extreme situation. They're sticking a whole bottle in there more than likely. They're not getting a chance to relax. Do you see what I mean by the difference on that, though? Alex, is that you?
Yes, that was me.
Good.
I guess I might have missed the other part of what was said, but as far as I'm aware, they're not going to get the initial effects because it's going to be too fast.
Right, exactly. And that's what I thought about in there as well when we talked about this, because the original question we talked about with butt chuggington, somebody who butt chugs, by the way, for those of you who are just listening, is somebody who puts like a funnel in their butt and sticks alcohol in there to absorb it via the rectum, going through the rectum into their anus, absorbing the alcohol that way. Most of the time, if you think about that, they're doing something extreme. They're going to stick alcohol in there, and they're going to keep sticking alcohol in there because they're not used to that effect. I originally asked after that lecture about what if they stuck a glass of wine in there? Could they get that relax effect? Because that wouldn't be nearly as much. They could get that relax effect, but if you're sticking a glass of wine in there, you're probably not the person who's going to be sticking a tube up your butt. Does that make sense?
Okay. What I was referring to was strictly like on the college level where they literally like stick a bottle of vodka up their ass.
Oh, heck no, you're not going to get the relaxed feeling. No. If
I knew with varying amounts, obviously, all things considered, that would be a significant difference, but
Jen,
what I was referring to.
Yeah, Jen, if you're talking about just general get that feeling after a whole bottle going in there, no. They're going to go away. They're going to pass out before they do anything, and they're probably going to have a lot of issues before they get any relaxed feeling. Does that make sense?
It seems like they're pretty much doing it to reach that intoxication feeling really quick because you were talking about it takes a while for it to absorb when you drink it regularly.
Well, it doesn't take a while for it to absorb, but you get that first 20% real quick to the stomach, and 80% starts showing up when you start going to the GI tract.
Right.
They're already getting that feeling when you start drinking.
But that full absorption, that rest of the 80%, is going to come on much quicker when you're going through the anus.
Right, and they are not going to be used to that, which means they're going to have issues. But we digress. We digress. Don't stick it in your pooper. That's what we're saying about this. Children. All right.
Party
For assessing a person who is an alcohol abuser, how are they going to talk? They're not current. Let's say they're not currently using alcohol. How are they going to discuss their alcohol use?
I don't have a problem.
Oh yeah, absolutely. They're going to downplay it or deny it. We need to explore this. Let's say they only have a few a night. How many is just a few? What else do you drink besides just beer? Is just a few to you a case? Or is just a few, you mean just a few cases? You mean, what does it mean? What's the legal blood alcohol content to be able to drive?
0.08.
Yep, it needs to be below 0.08. And 0.35 is dangerous. Medications we can use with this: Ativan, Librium, Valium, help with them. Withdrawals. Peak by the second day. Duration 5 days to around 2 weeks. What are some symptoms of those withdrawals?
Variant Cummins.
We have them bad enough, sure.
Nausea,
Transient
vomiting, fatigue.
Yep. Those are basics. We can handle those. We think about our harsh ones. The transient hallucinations can come. Seizures, vomiting. Just remember, this is alcohol. It's one of the things that can kill you with withdrawals. Detox may need to be with inpatient if it's a severe withdrawals. Don't forget, this is special based on what we're talking about, dilated pupils. Amphetamines, okay? First time we use, what are we going to get?
That's all you ever get.
Euphoria. Cloud 9 to the 9. Why do people keep using and keep using after that?
You're chasing that high.
Chase that high. They're always chasing that first euphoric feeling. They're never catching that. It's very easy to abuse, and amphetamines are used for weight control. Labs, brain CT, CBC, CMP. It's going up the nose more than likely. We're talking about cocaine, but we're going up the nose. You need to watch that brain CT. What's the initial effects of using this? Let's say cocaine.
Stimulant.
Why do people snort cocaine? What do they get immediately?
Euphoria.
Boom. Immediate euphoria. Methamphetamines give you psychotic behavior, but you get your immediate euphoria. So if you get immediate euphoria and you have a line in front of you, what are you probably going to keep doing?
You keep snorting it.
You're going to keep snorting it. You're going to have a rapid intoxication because of that euphoria. You're going to get hyperactive, anxious, grandiose, hallucinations. Your vitals are going to shoot up. Your chest pain is going to happen. Nausea, vomiting. What's going to happen if you overdose on this?
Seizure.
Seizures.
Die.
Your heart blows up.
I say cardiac infarct.
Yep. Medication, thorazine, coma. All right. Detox, thinking hours to days post cessation. Medications. If we're dealing with our detox, we want to control those symptoms. Librium to help them sleep, Valium. What are our withdrawals from this?
It's a crashing.
Crash. Remember, up, 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 up. down. Crash within 6 to 12 hours. Use, cravings, anxiety, fatigue, suicidal ideation. Everything's down. Okay? Can you die from withdrawals from this?
Nope.
Nope. But just remember, you can die from using it. There's a difference on these. We have to be able to separate that in our mind. Sedatives, hypnotics, anxiolytics, depressants, benzos, barbiturates. So, benzos are the most likely abused. Why are benzos more likely abused than barbiturates?
They're prescribed. They're prescribed often, right?
Well, they both are, but why are benzos more likely to be abused, though?
Isn't this like Barb is long and tall or something like that? It's really intense, really fast, and then it's over.
The general idea. Benzos are not likely to be used because they're not fatal unless they're IV. Intoxication, withdrawals is alcohol-like. What's the initial effect of taking a benzo or a barbiturate?
Drowsiness.
Drowsiness, and of course there's your definition, anxiolytic. Drop in anxiety. If you're intoxicated with it, what do you get? What are your symptoms? What are your signs and symptoms?
Very much like alcohol, right? Slurred speech, unsteady gait.
Yep. What kind of mood? Go ahead.
Liable?
Labile mood. Yep. And then you think the rest of them like alcohol. Like you said, slurred, unsteady, personality change, loss of concentration, memory, and judgment. Overdose. Can you overdose on a benzo PO?
No.
Well, you can. They just become lethargic. Benzos IVs kill you. And barbiturates kill you. Remember, never take on too many barbarians. Okay, rabble, rabble.
Yes.
I thought benzos doesn't kill you, right?
Right,
Overdose.
benzos don't kill you unless you take them IV.
Oh, IV. Okay.
The IVs, benzos can kill you. PO, no.
Okay.
All right, moving on through. Detox, what are we going to see? What do we need to do?
Well, the benzos you would flush out with IV fluids.
Yes. And what do we do with barbiturates to help with it?
Taper it off.
Taper, yes. Treatments include for barbiturates, ICU, GI lavage, active charcoal, normal saline. Why can we flush a benzo?
It's water soluble.
Water soluble. So where does it get filtered through?
Processed through the kidneys.
Processed through the kidneys. Whereas barbiturates are excreted through the liver, they're fat soluble, they can't be flushed. So, now we move into the withdrawals of this. Onset of withdrawals, 6 to 12 hours of using these. Duration, about a week. So, these things are downers. What do you expect is going to happen with these when you go into withdrawals?
You'll come up.
Up, 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 up.
I did.
Increase in vitals, hand tremors, insomnia. Again, barbiturates, you think ICU, coma, respiratory arrest, cardiac failure, death. Oh, background noise. You need to mute yourself if you got that. All right, hold on. Who's got it? Test, I've got to mute you. All right. All right. Cannabis, marijuana, THC. Again, we're thinking about that psychoactive resin of the upper leaves of the plant. Labs include that urinalysis, CBC, CMP. The urinalysis is more to see if it's there, though. So, how long is it going to be in a blood draw?
30 days.
30 days.
30 days. If you walk by a room with somebody who's doing this, is it going to be in your blood draw?
Not.
No.
It is approved for medical use in things like anorexia, glaucoma, chemo, AIDS. What's going to happen to your blood pressure when you use this?
Drop.
Yep. What happens to your pulse?
It goes up.
And what's another big sign or symptom that you're going to see with this related to the mouth?
The munchies.
Dry mouth?
Xerostomia. Yep.
Oh.
Xerostomia is dry mouth.
Yes, it is. All right. What's the initial effect like with marijuana?
It relaxes you. It's sort of like alcohol when you first start drinking. It relaxes you.
Yep. All you got to think about with marijuana cannabis, it's alcohol. Takes less than a minute, though. Peaks 20-30 and lasts for 2 to 3 hours. Drop your inhibition, relaxes you, gives you euphoria, but it gives you a nice increased appetite. Intoxication is unsteady. Drop in memory. Inappropriate laughter. Anxiety. No overdose. Your treatments for marijuana issues, symptomatic. What are your withdrawals?
There isn't one.
There are 4 withdrawals listed. They're very rare, but you do have 4 withdrawals we need to know.
Anxiety?
Yes.
But on her note, she
One.
said no withdrawal symptoms, right? On her
Anxiety, diaphoresis, tremors, muscle aches. All right. So opioids time. CNS depressant. A little bit. Yep. Labs. Again, CBC, CMP. We think of our EKG, our CT for our brain, chest X-ray, pneumonia related. Initial effect of taking an opiate. Why do we take an opiate?
Pain.
Pain. And of course you also get that euphoric feeling too, right? After that euphoria, what happens when you're intoxicated with it?
Get sleepy, drowsy.
Yep, drowsiness, slurred, apathy, loss of memory, pupil constriction. What happens when you overdose on these?
You die.
Well, death is a very good overdose, but before that,
Your respiratory,
So everything goes
yes,
down.
yeah, it goes down.
it goes down. Respiratory depression, coma, death. What do we treat this with?
A Narcan.
Narcan. And of course, you may need our naloxone, may need days of treatment. Remember with treatment, detox methadone can be used, which just decreases those symptoms to flu-like because it's a substitution. Do we have to give methadone for
No.
detoxing?
No.
Are they going to die if we don't treat them?
No.
No.
They're going to feel like they want to die. What are their withdrawals like from this?
Anxiety.
Anxiety, muscle aches, nausea, vomiting, diarrhea.
Yeah.
This is the big thing is your high stimulation. High pain, but no danger, and lasts for several days based on the drug. And this can be started by giving that Narcan. May have to isolate them. Insomnia, anxiety, dysphoria, cravings. All right, moving on to hallucinogens. What is the initial effect of taking a hallucinogen? Oh, come on.
You see things?
Yes.
Hey, good job! 5 points to
Just
Gryffindor.
like the name, hallucinations. Yeah, there you go.
Yup. And depersonalization. What happens when you get intoxicated with it?
You get paranoid because of the hallucinations.
Have a really
Yes,
bad
you-
trip.
Yeah. Oh my God! What am I seeing? You're depressed because you think the world's changing around you. You're paranoid. Everybody's talking to you. Therefore, it's called what?
Ideas of reference.
Ideas of reference. And again, your fear of losing your mind. Can you overdose or withdraw from this?
No.
Nope. But you can
You
brave
have
it.
flashbacks. You got flashbacks.
Yep. And you can go, oh yeah, based on what you see, you can have flashbacks. Symptoms. What are you going to have for symptoms with this stuff? What are your vitals going to do?
Go up.
Yeah. If you see giant elephants, riding Nazi balloons, your vitals are going to go up too.
Or dragons with fire
dragons
hanging
and-
around.
Hyperreflexia, you're jumping away from the dragons. Yeah. Psychosis, loss of contact with reality, delusions, hallucinations, detox. Your flashbacks up to 5 years after the drug's out of that system. Your analysis, CBC, CMP. Can they die from just the hallucinations?
If they kill themselves trying to get over.
Act on them.
Well, if they act on it.
Yeah.
Yeah.
If they see Peter Pan and they've got dust on them, they can fly from happy thoughts.
They actually can hurt other people. They start firing at the dragon.
Yeah, absolutely. I've got my magic armor on. All right, inhalants. Lab, CT, brain, liver panel, CBC, CMP. Bloodshot eyes, inhalants. Look at that kid. He looks smart. All right, initial effects of taking an inhalant.
Like cocaine.
Why are these kids taking inhalants?
It's like cocaine.
Gets a little high.
It's mind altering. Yeah, it's a little bit of, I think it's like a 3/4 second mind altering effect.
Yeah.
When they're intoxicated with it, what do they get?
Dizzy,
Dizzy,
steady gait.
right?
They're not nice. They can be mean and belligerent.
Right. Look at them. They're all red-eye. This is your specialty one. They're inhalants with red eye. They're so angry and belligerent and assaultiveness, they've got red eyes. Belligerent, assaultive, impaired judgment, dizzy, vagal stim, tremors, euphoria, dysrhythmias. Signs and symptoms of this. What do you see, not in chronic, but somebody who's just used or is using?
Nosebleeds.
I don't know what a nosebleed is.
Epistaxis.
There you go.
Sores around the mouth and the nose.
There you go. I don't know what a sore is.
Piss on you.
Infectious lesion?
There we go. Epistaxis, red eye, nystagmus, infectious lesions around the nose, mouth, disorientation, unconsciousness, and that's syncopic episodes. Chronic, progressive brain damage, asphyxiation, seizures, and bone marrow suppression. Here's a great thing to start thinking about up here now. We're talking about our CBCs. What are we going to see with their CBC, with that bone marrow suppression?
Decreased red blood cells.
Yeah. Bone marrow is being suppressed. Where do our red blood cells, and where do all our blood cells pretty much come from? Creation. Erythrogenesis. Where does that occur?
Bone marrow.
Bone marrow. And if it's being suppressed, good, you know, we're going to start seeing a change there if it's chronic, right? Again, just think about your connections. Beep, beep.
That's a lot of burp, wasn't it?
Inhalants again. What are our withdrawals?
Depressed.
No real withdrawals, but they just have psychological cravings.
No.
Detox, we monitor their vitals, respiratory and cardiac function, because they just inhaled pains. There's not really an antidote or treatment for this. Their brain turns white. What age range are you probably going to see this in?
Teens.
Teens, right? Adolescents. Why do they use this?
It's cheap. It's available.
Cheap, easy to get. They're uneducated, more than likely, on this stuff. What do they have a high risk of occurring because their brain is still developing? Mental retardation.
Mentally handicapped.
You have mental retardation. All right. Treatment objectives of recovery, just to kind of show you the slide. We have our detox, which is our first step of recovery. You want to make sure that's a safe, supportive environment, inpatient. Substitution treatments can be part of the detox, methadone, Suboxone. Intermediate care, rehab, outpatient, identify causes of that dependency. Rehabilitation, health promotion, outside support, and get new, safe sources of satisfaction. Like paintball. All right. Treatment modalities. Blah, blah, Fallout Boy. Strong personality is required to keep straight. He's a pretty cool guy, so he's a pretty good personality. So, we're talking about client family education first. Why do we need to educate the client's family as well as the client when we're talking about treatment?
So they can recognize the first signs of a relapse.
Right.
The person's going to need a strong support system.
Correct. One more thing.
Stressors that may trigger
Also, they must understand why they started using.
access for.
Yep. All of this stuff, everybody was right on that one. We have to have a good support system, see everything that's going on, and figure out what caused them to start. Now, support groups, think about educating them, problem solving, identifying, modifying faulty thought patterns. And for the pharmacotherapy, we want to help them with safe withdrawals and to prevent relapse. We've got our counseling. We have group therapy like what?
JA, NA.
AA, NA, yep. Now we've got our psychopharmacology for the intox and withdrawals. What's our prognosis for people? If they're a first-time user, what's their prognosis? And they get treatment.
It's pretty good if they're a first-time user, right?
Yeah. It goes beyond that after that. Fair at second and beyond, and they use again. All right. Now, let's do our nursing process for this. Remember, this is about using something. Early detection is key. Getting them in detox is a priority. We have to follow Maslow's after that. What are they going to look like? What is their appearance going to look like? This could be anybody. This could be the hallucinogens, the opioid, the alcohol, the amphetamines.
They can be apprehensive or have anxiety about the whole process.
Appearance.
They're going to be disheveled, unkempt.
Yeah, jittery, hands
They
shaking.
can look normal too. They may show signs of anxiety, as you said, related to that treatment, but they could be in businessman attire. But they could come in completely disheveled, unkempt as well. It just depends on what this person's dealing with at that time. That's the whole idea. We can't judge based on what we're looking at. What's their mood and affect?
They can show a variety of moods. They can be happy or angry or depressed, depending on where they are. Last time they took whatever they were taking.
Yep. Why? Happy, angry, so on. It just depends on what's going on. Happy they're getting treatment. Angry because they're forced into treatment. So on because they're like, oh, we're here again. What's their thought processes like?
A lot of times they're in denial. They don't think they have a problem.
Yep. Like they minimize it, abuse, like blame others or rationalize what they do. Is there anything wrong with their sensorium? No. Times 4 unless they're actually in withdrawals right now. Judgment, good or bad? Somebody who's using a substance, is it good or bad if they're for judgment?
They're just thinking about when they're going to get their next drink or their next high.
We're assessing them. They may leave and go get the substance that we're treating them for. It's poor judgment. Self-concept. Yeah, it's low. Direct, express, and they may actually show grandiose behavior to cover up that low self-esteem. Their roles: absenteeism at work, strain in the family. Physiologic: poor nutrition, poor sleep, liver damage. They could have HIV or hepatitis with the IV use, or neurologic lung damage. Here's a fun sheet. Give me some nursing diagnoses for this patient.
Powerlessness.
That'd be good for something like cocaine.
Ineffective denial.
Absolutely. Excess fluid volume, risk for injury, imbalanced nutrition, ineffective role performance, ineffective coping, dysfunctional family processes, alcoholism, self-care deficit. Then we've got our outcomes. The patient will abstain from alcohol, will express feelings openly, will practice non-chemical alternatives to dealing with stress or difficult situations, will develop an effective aftercare plan. Now, what is wrong with these outcomes right here?
There's no time limit.
Oh, bam.
So if you had to choose from the list of nursing diagnoses as your top priority, how would you determine that?
It's going to depend on that patient, honestly. If somebody's suicide, there's your safety. Always remember safety first. Always remember safety first. That should always be what you're thinking about as your baseline.
So do you use, because I thought that risk for was always less of a priority than an actual diagnosis.
That is true.
But if they're going through withdrawals, if they're withdrawing from alcohol, they're going to be risk. And that's going to be your top priority because you're going to be looking for things that are going to happen.
Right.
Because the withdrawals from alcohol could kill them, so they're at risk.
Right. Risk is almost never used as a primary. However, we know with alcohol, when they're withdrawing from it, they have some major symptoms that could occur because of the road they're on. And risk 4 at that point is part of that safety, part of the issue that we're watching for, because that's the only thing ahead of them is this withdrawal. We're not dealing with coping, we're not dealing with any psychosocial issues. It's that withdrawal, those withdrawal symptoms that could occur next. Because we know they're in withdrawal, we're not set for withdrawal. They're currently in withdrawal. And again, we've seen questions about these, but remember, a lot of these questions will say, what would be your primary nursing diagnosis for a patient in alcohol withdrawals? Which means they're in it. So you know that they may show some signs. So the risk for, risk for seizures, risk for DTs, those types of things are an issue.
Okay.
You wouldn't say risk for suicide necessarily, depending on how bad that is. But if that was there, that'd be kind of a hard question, because if they're having a really bad one, that could be there.
That helps, thanks.
That's fine. Yeah, there was a question actually about that I found. I didn't put that in our practice, but it had an alcoholic in withdrawals, and I'll see if I can find it again and put it there now that we've had our time with it. But it had an alcoholic in withdrawals, and it said, what's your primary nursing diagnosis? And it said, risk for DT, risk for seizures, risk for suicide, or ineffective coping. Which one would you think?
DTs.
What'd you say?
DTs.
Nope.
Risk for suicide.
Yep. Patient can't handle the pain. We're going to be treating everything else, but that suicide ends everything. And I was like, oh gosh. So it was one of those high-level questions I was not ready for the first time I saw it. I was like, oh, okay, good one. So just make sure you watch that suicide. Suicide's something that ends everything. So if your patient commits suicide, the psychosocial questions kind of end, right? Remember, for our interventions, we've got our health teaching and spell myths about substance abuse, decrease that codependence among family, make referrals as needed, role play difficult situations, evaluations, we want to increase that role performance. But what is key on the evaluation portion of this? We're evaluating a patient who abuses a substance. What is key to all evaluations? That they abstain. Heavily depends on abstinence from that substance. All right, elder considerations. Over 50. Why do elders start using?
They failed to meet their goals.
Mm-hmm.
Or they
We've heard this slide 1,000 times, but every time it's the same idea. Go ahead.
They've lost their loved one.
Mm-hmm.
Chronic pain.
Mm-hmm. Illness and pain, long-term meds, social isolation, grief, lonely, money issues, unable to care for themselves, ADL issues. Remember, when we start getting into this, health professionals. One, if a patient is in one of those care facilities and they're supposed to take care of their meds, and they miscount or start using those meds and abuse it, they have to be let go, removed from that project. But this also counts for health professionals. If there's incorrect counts, wasting of drugs incorrectly, ineffective patient pain relief, incorrect documentation, damaged packaging, we are ethically and legally obligated to report this as suspicious activity. They may support from that Tennessee Board of Nursing. This doesn't necessarily mean they're doing anything wrong, but they may need help because it could look bad on them. but they could be doing something wrong as well. Now, fun slides. What substances will kill you if you are intoxicated from them? Just think back to the slides we just did. We just did them, so you should have pretty easy answers.
Barbiturates.
So, what'll kill you if you're intoxicated from them?
Barbiturates.
Alcohol and opioids or opiates.
Opiates will kill you, yep.
Did you mention?
Alcohol, I forgot to put alcohol on the actual list. I forgot to type that in there. But yeah.
Space said barbiturate.
Barbiturates.
Cocaine.
Cocaine, amphetamines, benzos, IV. Barbiturates, opioids, hallucinogens, PCP, specifically, related to the seizures, but acting out the belief would actually cause you death. So the medication is not doing it, but inhalants, alcohol, you can type that in. Now, with intoxication, only 3 of these things will let you live if you get intoxicated with them. Marijuana, hallucinogens, and benzos. So remember, if you're intoxicated, my hot body won't kill you while you're intoxicated. MHB. Which drugs will kill you if you're withdrawing from them?
Well, alcohol.
Alcohol. And
Barbiturates.
there you go. You're going to live with opiates. You're going to live with hallucinogens unless you fly. Cannabis, cocaine, you're going to crash. Hallucinogens will give you a flashback. Inhalants give you psychological cravings. So withdrawals, you have AB, will kill you. And with OD, it's easy to remember which ones don't kill you by saying MHB. My hot body won't kill you if you're intoxicated. And that is our review of that.
Thank you.
Test day. All right, so we have gone for a good 2 hours. We're not going to do questions, seeing how we did 2 PowerPoint slides, so I'm going to post this. I hope you guys enjoyed, and we're